السلام عليكم. في الأول أحب أهني على نجاح المؤتمر العظيم ده، وأشكر كل القائمين من المستشفى المنظمين، وأشكر ال chairpersons. Initially, I'm not a surgeon and also I'm not an anesthesiologist. أنا مش جراح ولا طبيب تخدير. Why I'm here? To send some messages for you, please. Starting by enhanced recovery after surgery. What is our aim as a physicians in general? Good outcome for your patient. So we try to focus. And what is the relation between surgery and ICU? ICU started long times ago by Dr. Professor Cushing, very famous neurosurgeon, and Dr. Dandy, also a neurosurgeon. They noticed that for their meticulous surgical advances and work at that time, the mortality rate was 80%. So they're losing their effort, their time, and their patients also. What these guys did, they focused on the post-operative period. And is there an achievement? Yes. The mortality decreased from 80% to 8%, 1/10. And a good statement from Professor Cushing, this Dr. Cushing, very famous in any textbook for medicine, physiology, anatomy, surgery, and neurosurgery. I'd like to see the day when somebody would be appointed surgeon somewhere who had no hands. For the operative part is the least part of the work. I've been proud to work with this fantastic team. Very big names in the vascular surgery. They did a meticulous work and very advances in vascular surgeries also. And they have good evidence, you cannot doubt that. The angiogram pre and post surgery. And what is the problem? Why should a technically successful operation and no doubt from angiograph result in an unsuccessful outcome? Something should be behind. And as a physician, most of people currently thinking about changing the career or do career shift. This is a famous doctor, famous surgeon, GI surgeon, Professor Henrik Kalt, a Danish professor in surgery. What he mentioned, and he tried to solve this problem for post-operative complications. And he, from the 1990s, started to focus on multimodal approach for the post-operative pathophysiology and interventions to solve this problem. A lot of cascades, mechanisms, and pathways to focus on the post-surgical stress response. Because of time constraint, we couldn't go through these all elements. And to come, what are the consequences of surgical stress response? You are excellent surgeon, but what about the outcome and what will come to the patient during the post-operative period? As you can see with me, your patient is suffered from hypothermia, coagulopathy, immune suppression, hyperinflation, leaky blood capillaries, endothelial dysfunction, mitochondrial dysfunction, gut wall ischemia. And this will end by major organs affection like pulmonary complications, brain infarction, and cognitive dysfunction, acute kidney injury, acute liver injury, atrial fibrillation, myocardial injury, and myocardial infarction, infectious complications. This will happen in the post-operative period. So your patient will end up by what we mentioned, multiple organ dysfunction syndrome, very remote organs from your surgical side. And now, major surgery is the neglected childhood of the global health. Regarding the surgery, mortality, intraoperative, fortunately is very minimal nowadays because of its advanced techniques. However, The 30-day mortality is not. And you cannot imagine the mortality and complication from surgery. Every 1 hour passing in the world, we have 1,000 mortality related to surgery. We have 4,000 complications related to surgery. And fortunately, 50% can be prevented. In the era of COVID-19, we should consider post-operative complications as a hidden pandemic. Please, doctor, when pushing your patient to operative theater, you are pushing the patient to a long marathon. So what will happen after that? He will collapse. Your patient going to surgery, if he's healthy adult, what will happen? He has increased energy needs, major workout like running 2.5 hours, major muscle loss, lowered immunity, insulin resistance, and unintended weight loss. So what do you expect in recovery phase? For this reason, Dr. Henrik, what he mentioned and what is the aim of ERAS, or enhanced recovery after surgery, to attenuate the impact of surgery and to promote early recovery. And it is evidence-based. It was associated with reduction in hospital stay, reduced post-operative complications, reduced the cost, and improved the patient comfort and satisfaction. The cornerstone, evidence-based post-operative care, multidisciplinary and multi-professional approach, teamwork, continuous interactive audit and reporting, data-driven changes, and readiness to make the next change. And the latest updates and guidelines from ERAS group, it published in mid 20 and 22. This is the protocol, and these are elements covering the patient journey, pre-operative, intraoperative, and post-operative. Because of the time also, I try to focus for some important points. Please, I advise everybody working in surgery and anesthesia and post-operative ICU to go through all these elements. Optimal analgesia for surgery. Thankfully for Dr. Ansari for putting good highlights regarding the post-operative pain management. This is the model for perioperative analgesia, opioid-based or non-opioid-based. All of us thinking the painkiller should go through opioid-based, which is the old way. Again, one important point, pushing the patient to this marathon and was losing a lot of energy. So what do you need? To keep him fasting long time, from midnight and his scheduled maybe in the afternoon? Definitely not. What are the recommendations and guidelines from ASA, American Society of Anesthesiology, in 1999, very long time ago, for fasting regular heavy meals 8 hours, and for water and clear fluids 2 hours. You should not keep your patient fasting and dehydrated. This is from 1999. Any changes after that? And the ASA also, the updated one in 2017, the latest one, 2017, no change. So what we are doing? Also, all societies, big societies all over the world, Canada, Australia, New Zealand, Europe, also recommending the same. So our recommendation should not keep the patient fasting. And we should not cancel the operation because the patient just take a drink. Another point, very important, I advise also surgeons and anesthesiologists to focus on what we call preoperative carbohydrate load. 2 hours before pushing the patient to OR, you should give him high dose of carbohydrate for non-diabetic patient for 2 hours with evidence-based and strong recommendation. So a complex carbohydrate drink of 400 ml with 50 grams carbohydrate should be given 2 hours before surgery for elective patient with a strong recommendation. For the cliché of post-operative plan of care, keep NBO, NG-free drain, intravenous fluids, antibiotics, consider TBN donates plasma to every 12 hours. This is a very common cliche stamping in the post-operative order. Actually, and very surprising for some bodies, fluids should immediately be resumed after surgery, and for solids after 4 hours. Post-operative nausea and vomiting, we should consider it and putting a score and try to tackle it before the post-operative period. For post-operative nasogastric tube, because I noticed many surgeons keeping the NG tube, even putting restraints to avoid the patient pulling it out. And what is the recommendation? Avoiding routine nasogastric tube emplacement is recommended, and high evidence with a strong recommendation. Avoiding the routine use of peritoneal and pelvic drains is recommended. I'm talking here for elective and definitive surgeries, not for damage control. And Forest catheter should be removed in the majority of cases within 24 hours of surgery. Also high evidence and strong recommendation. For early mobilization, the recommendation to sit out of bed 30 minutes on day 0, on the same day post-operative, and 6 hourly every day thereafter, and commence walking in day 1, with a strong recommendation also. We are here for laparoscopic surgery conference. So does laparoscopy surgery had any positive impact in the outcome and early recovery? Regarding the systematic review, including more than 300 articles, and it was reproducible advantages of laparoscopic surgery: faster convalescence, reduced hospital stay, and fast return to normal activity with decreased incidence for wound incision, wound infection, and reduced perioperative mortality. For this reason, now laparoscopic surgery is considered the gold standard for surgical interventions. Is there any advantages when combining laparoscopic surgery with ERAS protocol? If you are noticing in this study, comparing the interleukin 6 for operative cases, open surgeries alone, or open surgeries with ERAS or fast track protocol versus laparoscopic surgery and laparoscopic surgery with ERAS protocol. And they note significant reduction in IL-6, which is a significant inflammatory marker, with each element. The highest one is surgical or classic surgical open surgery, and significantly dropped when putting the fast track protocol or ERAS protocol. Again, comparing laparoscopic surgery with open surgery, significant reduction in IL-6, and still positive when combining the ERAS protocol with laparoscopic surgery as regard the interleukin 6. So, we are here for laparoscopic surgery conference, and we are in 2023. We should not use protocols and traditions which dated on 1946. Again, all is well that ends well. إنما الأعمال بالخواتيم. Thank you.